time and what you need to do in case you see a patient with certain symptoms. So today we are going to have a talk on lung cancer and its early detection. So we are going to have two speakers, Solomon from KNH and Dr. Valerian Mwenda from the Ministry of Health NCD Division. So Solomon will take us through the content that is actually on the e-learning platforms. He's able to show you how the content flows so that you can also go and check out the content yourself. We shall be showing you those platforms in the course of the discussion. So welcome all. Let's learn about lung cancer. Solomon, you are up. Do you have your slides ready?
Hello.
Hi, Solomon.
Can you hear me? Hopefully I'm audible.
Yes. Yes.
I don't know whether Dr. Jeffrey had shared the slides with you.
Do you need me to project for you?
Please, if you have, you can project them for me.
Okay. Meanwhile, you could be introducing yourself. Tell us what you do.
Okay, thank you so much. As the moderator has already introduced me, my name is Solomon Mare. So Solomon is an oncology nurse. I currently work at the nursing officer there. Way and beyond that, I'm also participants are rather post manager for lung cancer, the MoH Virtual Academy. So as the moderator has already put it, the slides that we're going to look at today, the entire content basically is found on the M-Saratani platform, which was introduced to us on Monday. Dr. Jeffrey talked about it. The same can also be accessed through our. If you want to go online, you can also access them through the Ministry of Health Virtual Academy. That's under the and communicable diseases. So there are many. You can still go to the cancer series, select on the specifics slides that you want to look at. So today I'll be taking us through the content that is found on that is module 5 on the lung cancer. So I'll first go through the slides, the explanations here and there, and then probably there'll be a session for question and answers there before. Thank you so much. So as it has outlined in our screens, hopefully everyone can see it. The entire lung cancer module is divided into 3 sections, those 3 sessions. So the first session takes us through the definition of lung cancer, the epidemiology, and then on it we look at the risk factors and early detection. And then in section 2, we look at the clinical evaluation and the diagnostic algorithms available for lung cancer. Then lastly, there'll be a session on treatment, palliative care, and supportive care lung cancer. So it's generally a wide area, specifically designed for healthcare providers, different sections of the healthcare system, either on the lower level, the lower tiers of the tertiary hospitals, what we currently call the teaching and referral hospitals. So basically, it's a module type of presentation. Welcome. Let's enjoy the session. So basically, when we talk about lung cancer, kind of a, let me call it, it's kind of a critical condition because the way it presents more or less the same as most of our respiratory diseases. Most of the respiratory diseases that we know can mimic the same thing. It can come as a differential for tuberculosis, as a differential for chronic respiratory syndromes that we know. So basically, this module should help us so that we can develop a high suspicion index. So by definition, we shouldn't look at lung cancer basically as a cancer that affects only limited to the lungs. So the lungs, it can come in 3 different levels. So it can affect the trachea, the bronchi, and the alveoli, the components that form generally the respiratory system, all the way from the trachea down to the alveoli. So on this module, our main thing should be looking at how can we increase the suspicion. So having talked about the definition, lung cancer is not just lung cancer. It's about in two main subtypes. That is the non-small cell lung cancer and the small cell lung cancer. It's critical that we understand this because the treatment approaches, even the way the cancer will present in itself, will be different. So the treatment approach for small cell lung cancer is a little bit different with the treatment approach for non-small cell lung cancer. And again, you realize that within the non-small cell lung cancer, there are some minor subtypes. You'll find a subtype like squamous cell carcinoma that generally accounts for around 25% of the lung cancer cases in the clinic, the ones that are diagnosed globally. It can also be an adenocarcinoma that contributes to around 40%. See? And then way and above that, it can be a large cell carcinoma, or what is commonly called the hot cell carcinoma. Very aggressive with a very poor prognosis subtype. Then another large subgroup is the small cell lung cancer. That incorporates the fast growing cell that contributes around 10 to 15% of the total lung cancers that we see. So there could be other subtypes that can be include the lung cancer, the sarcomas and the lung lymphomas, but generally the major ones that we see in the clinics are the small cell and the non-small, the small cell and the non-small cell, where the non-small cell contributes around 85% of the cases. So epidemiology of lung cancer is a little bit complex. If we look at the global cancer statistics, up until 2020, lung cancer was among the cancers that had the highest incidence. But after the 2020 global cancer statistics, breast cancer overtook it in form of incidence. But when you look at the mortality cases, lung cancer is the leading cause of mortality on cancer-related deaths. But in terms of incidence, breast cancer are the major cases. It's quite complex again. Probably should be up for a research. Is it? We look at developed countries vis-a-vis the African, what we call the sub-Saharan region. The incidences are quite a contrast of each other. Whereas we talk about lung cancer being among the most common lung cancers, we look at the numbers that are emanating from Saharan, they are quite low. So probably been postulated that the reason for this is either we are undiagnosing lung cancer, and by this module, it will help us with suspicion index so that we are able to cases that the missed cases that we normally undiagnose, so that they are brought to book for early detection and treatment. It's quite funny again in Kenya, like look at the statistics, that is the global cancer statistics. The incidence was around 670. But finally, we had around 659 deaths annually. That's quite a jump. I think a survival rate of less than 10 cases. Let me call around 11 cases, according to these statistics. It means that we need to employ a lot of strategies in order to try and combat it, because the incidence vis-a-vis the mortality is quite disturbing. So having looked at that, I had already said that the non-small cell lung cancer 80 to 85%, that broken down the cases where we can have the squamous cell carcinomas or the non-squamous, which includes the adenocarcinoma and large cell. Then when we talk about the small cell, I talked about it contributes to around 15% cases. the major risk factor. Of course, when we talk about risk factor, is the odds ratio. It doesn't mean that it's only smokers who will be predisposed to lung cancer. The major risk factor for lung cancer is smoking. Smoking, so it contributes to majority, around 70% of advanced disease. 70% of advanced disease, of the disease, they come at advanced stage. The diagram that we see there is giving us the age standardized incidence and mortality. This is for Kenya. Look at lung cancer is among the, like I've explained it earlier, it's among those that are contributing the lowest incidence. But you look at the global picture, is the second leading. So it raises a lot of questions. Is it because of the undiagnosis, or we're generally having lower incidences? So it's a question that we need to carry. It's a discussion that probably we need to carry forward as we even go through this, this course. So we need to increase basically our suspicion index, so that if we are diagnosing, we can bring the missed cases to book. So what are the risk factors? Just like any other cancer, risk factors can be broken down into two viable risk factors. The ones that we can influence, the modifiable risk factors, and then we have those that we cannot influence, that is the non-modifiable risk factors. So under the non-modifiable, across two major ones. Age is a major risk factor for most cancers. So lung cancer is included in that. So under the age, we look at patients above the age of people above the age of 55 to around 74 years. That is the peak age for lung cancer. And then we also look at the family history of lung cancer. We talk about cancer being an inheritable, where there are chances of inheritable gene predisposes, so it increases the odds of developing cancer, not only lung cancer, but most of the cancer. Other major exposures, other major risk factors, the modifiable that we talk about, the leading cause of it all is tobacco smoking or exposure to tobacco, either as an active smoker or as a passive smoker. And studies have indicated that it gives us, it increases the odds ratio to around 85% of all cases. It's been associated with the tobacco smoking. And then, of course, we have other exposures, environmental exposures, such as asbestos and radon exposure, especially when we talk about the large cell and the small cell lung cancers. The environmental exposure plays a very large role towards that. Other risk factors include chronic lung diseases. So the chronic, an example we can give is the COPD, that is the chronic obstructive pulmonary disease, and TB, and in a way it places a differential to that. There are many, but these are a few that have been highlighted, and the major ones. If we can go to the next slide, please. So having looked at the risk factors, what are the early signs and symptoms that we can pick? Before we start looking at the 10 signs and symptoms that we can have for lung cancer, it's important to know that, as I earlier indicated, that we have two major subtypes, that is the small cell and small cell lung cancer. So the treatment options are different. Also wanted to know that, yes, these are the general symptoms, but symptoms again can differ from one subtype to the other. So much as we talk about, and then again, another major impact that can cause a variation of the symptoms is the specific location of the tumor within the lung. A lung that is a tumor that is starting from the trachea, or a tumor that is starting from the periphery of the lungs, might present differently as opposed to a tumor that is having its root, or that is emanating from the central parts of the lungs. But generally, the major signs and symptoms of lung cancer that we have, as you can see, they are well highlighted there. So we have a hacking cough as number one major that we can have. And then basically we talk about the respiratory symptoms, talk about shortness of red. Something that we need to elicit. And as we elicit, when we find a patient presenting such symptoms, it's always good to elicit, like, for how long has the patient had them? Is there any other treatment that has been done? So depending again whether it has there's a local metastasis, the patient can come up with that chest pain, very disturbing chest pain. You can also have hemoptysis, that is the blood stain sputum. Way and above that, we can have, depending again, we have any something like superior vena cava compression. Patients will tend to have, depending, they will tend to have like edema of the upper extremities of the brachiocephalic region. Way and above that, we also talk about generally loss of weight, loss of appetite, loss of weight, and then there is a generalized body weaknesses. These are brought as a result of reduced oxygen concentrations in the body. But those are the major signs that we see. So in summary, we talked about lung cancer being among the commonest globally, but very low numbers that are emanating from the African region that have been attributed to this diagnosis or undiagnosis. I don't know whether you can relate it from your various places of where you practice. So smoking is the major risk factor for cancer, and in smoking, it can either be as a passive smoker or as an active smoker. So early detection, basically generally for all cancers, early detection is key to treatment. Next. So that is the session 1. And then now in session 2, we look at the clinical evaluation and diagnostic algorithms. If you go online, there's a very good risk stratification that has been done by NCCP. It's also on the content. So if you can find it, it's very advisable that you look at it, because it generally tends to cluster the risk factors and the suspicion index. So there's a high risk and low risk. Probably we'll find time we'll look at it. So under clinical evaluation, we are urged to suspect cancers. We are urged to suspect lung cancer in patients with persistent pulmonary symptoms. For example, if you are in a setting where you've been treating patient X for a long duration of time, probably you're treating for TB or for a chronic pulmonary disease, and there are no cases of improvement, there are no signs of improvement. So that is a large, it's a queried area where we need to suspect lung cancer and probably send for and order investigations that can lead us to that. Way and above that, we also need to assess for the risk factors. The risk factors that we had early talked about. We talk about smoking history. We talk about the history of alcohol intake, the family history of lung cancer or any other cancer, or a history of exposure. We talked about asbestos and the radon exposure. They tend to increase the odds of lung cancer. So if a patient comes with such a history, we need to be highly suspicious. So after we get the clues of this, it's good to document again our past history. So this history should include the history of chronic lung diseases or medications that have been used, if they are available, and any other relevant history. Because essentially what this should do is that it needs to help us increase the suspicion index for lung cancer or any other malignancy that is there. So in clinical evaluation, if the patient is presenting with the symptoms that we had initiated, it's very important that we look at for, we inquire, we probe more on the onset and duration of this. Especially if we're talking about the primary lung lesion, patient will present with cough, dyspnea that is difficult in breathing, chest pain, and blood stains sputum. Or some instances might come with wheezing. So it's good that we probe more on the onset and the duration. And then besides the key symptoms, we also look for the supporting symptoms, such as, is the patient having anorexia? the patient having an unexplained weight loss, are there chances of sweating? I know in TB we talk about night sweats. It's always good to elicit this. And then we also look at symptoms of regional inversion. So this can be local metastasis or distant metastasis. And among the major ones that we need to look at is superior vena cava syndrome. So the superior vena cava syndrome is basically the obstruction when that lung tumor tends to obstruct the superior vena cava. You know, the superior vena cava is a junction, the cephalic junction, where, so major symptoms, like I talked about in case of a superior vena cava, we look at edema of the facial edema and edema of the brachial region. So if there is a suspicion of a superior vena cava, and in oncology, that's an emergency that needs to be attended to as soon as possible. Another major syndrome that we need to look at is the Horner syndrome, or the brachial obstruction. So when we talk about the Horner syndrome, what basically we are looking at is it can come as a result. It can come as a result of a tumor, or it comes as a result of basically a person is born with it. So in Horner syndrome, can be congenital, like I've said. Basically, it involves where the sympathetic nervous system has been extensively interrupted with as a result of the tumor invasion. So the patient is presenting with the sympathetic symptoms, or rather the involvement of the sympathetic symptoms, we need to suspect the Horner syndrome. Way and above that, we can talk about the dysphagia. But when the tumor is enlarging, it tends to press against the surrounding organs. Patients will present with some of the local symptoms such as dysphagia. You can hear me next? Thank you. So if we are suspecting, under clinical investigation, if we are suspecting that there are chances of a local inversion, or rather there is a metastasis, so we need to do like a system examination, evaluation of a systemic evaluation. On this, we look at the skeletal system. There are chances of bone pain and tenderness. You know, the lung is so proximal to the chest wall, the ribs. So patients might tend, if there are chances of bone involvement, bone pain, sometimes tenderness. There can also be CNS involvement. So under CNS involvement, there can be reported cases of seizures, and patients will present with headache. And especially if there is metastasis, there will be major sensory and sometimes motor deficits that can be observed. Way and above that, the liver is another critical organ that can be affected as a result of a metastasis. So we need to check the liver function tests. Basically, look at the liver involvement. We can talk about hepatomegaly in case there is liver involvement. Another major symptom that occurs in lung cancer is the paraneoplastic syndrome. So paraneoplastic syndrome occurs when there is a systemic reaction, between the tumor, where the tumor antibodies are coming up against the immune system. So patient will present with a very paraneoplastic syndrome that are not like the pseudo-hormonal systems, pseudo-endocrine symptoms that can present as a paraneoplastic syndrome. So there are many things that we can elicit. There are many things that we can elicit in case of local or distant metastasis. They are not only limited to this, but these are the major and the common ones that can present. So under the diagnostic modalities, so after we've done our clinical evaluation, that is based on the history and the physical examination. So we can subject our patients to laboratory or radiologic examination, and under the laboratory examinations, under the imaging examinations, the most common ones that we use is the chest X-ray. In the slides, we'll be looking at some of the films that can depict a tumor. But I'm sure most of the practitioners here they have that comfort to differentiate between a normal chest X-ray and an X-ray, a chest X-ray that is showing signs of an invasion. Another key imaging modality that can be used is the CT scan, that is for the chest. That can include abdomen and sometimes the adrenals. So besides the imaging studies that can be done, we can also do the laboratory investigations, where the key things, when we look at the electrolytes, we talk about the paraneoplastic syndrome. Under the paraneoplastic syndrome, patients will tend to have extremities of the electrolytes, especially the calcium levels. And you know, when calcium levels are way, way below the abnormals, they tend to have an impact on the vascular system. Another key laboratory investigation that we look at as a baseline is the liver function test. We've talked about the liver involvement, especially when we are doing our metastatic studies. Sometimes it's common to have, like I initially indicated, it's common to have the range or the metastasis, the liver. Then another baseline, CBC, that is so common to most of the common baseline investigations that we do. And CBC, we are able to depict some of the abnormalities. Probably the WBC should be deranged either on the higher side. So we can also do the pulmonary cardiac function tests, post-expiratory pressures. These are the respiratory functions, mostly done in the level 3 level. That is the county referral hospitals, the national referral hospitals. I'm not so sure whether they could be found in the primary health settings. But echo is one of the major tests, pulmonary and cardiac function tests that can help us like increase our suspicion index. Where and beyond that, we talk about the vital capacity, and this should help us determine if the patient has an eligibility for surgery. It's always good to note that surgery again is not applicable to all subtypes of lung cancer. Specifically useful when we have early stages of the non-small cell lung cancer. I'm not so sure whether surgery is indicated for the small cell lung cancer, but it's in very, very rare occasions. But the major ones where we can have surgery indicated is among the non-small cell lung cancer, but that is the early stages. So next on the slides, we have the images of the X-ray, like we talked about some of the imaging studies. There are pointers pointing us to the tumors. I'm sure we can see that from our slides. These slides have been they were obtained from the diagnosticandimaging.com. That is the source of these slides. They're able, you know, like I said earlier, most of the clinicians are able to differentiate a normal chest X-ray from an abnormal, and you can clearly pick out a tumor, especially where there are cavitations. You're able to pick out a tumor. So in the preceding slides, we look at some of the films that point out to the presence of a tumor. If you can go to the next. Next. You can hear me, please. So on that one, it's giving us basically the different parts of the lungs. We have the trachea, you can see there is the aorta, the left lung and the right lung, and where the heart is. And we can pick some of the cavitations that the tumor, where the specific parts where there is a tumor. So it's critical that we know to analyze this, especially for the clinicians who are able to read and interpret the findings from a chest X-ray as the basic diagnostic model, rule out other pulmonary or respiratory diseases. Next. Next, please. I think it's more or less the same thing. We can look at the permutations and be able to differentiate. So on the next diagram, we have the CT scan. Those are the images of the CT scan. Again, if there is a suspicion from the X-ray, so we can probe further and do a CT scan tends to be more finer, especially when we want to elicit the specifics of the tumor, whether it's centrally located or on the peripheral sites. Now, the CT will tend to give us finer details of the finer details than the X-ray. So besides that, the biopsy, the lung biopsy, gives us the definitive. We talked about the diagnostic modalities. These ones will tend to increase the definitive. We tend to increase our suspicion index towards lung cancer. So if you have gotten to a point where you can say that I'm suspecting lung cancer, we've been treating TB for some time, we've been treating a chronic pulmonary disease for some time, and now we've done the imaging, the definitive diagnostic criteria for many cancers is the biopsy and pathological studies. So in summary, we talked about the common symptoms of lung cancer. It tends to mimic the respiratory or the cardiovascular conditions, especially TB in most settings. So this, whenever we have TB being treated without change, it needs to help us develop a high suspicion index. The main diagnostic modalities we talk about is the imaging, where we use the X-ray or the CT, but the definitive, as we've concluded on our session 2, the pathological studies will tend to give us more definitive treatment. So on our last session is the treatment, palliative and supportive care, and follow-up. So one thing that I need to talk about as we look at the last phase is that depending on the unit, on the setting where you are operating as a care provider, you are always free to refer for a second opinion or to refer to higher levels, especially for the services that you are not able to provide when you have a suspicion index. The aim is to try to come up to try to get to those cases of lung cancers that we miss, so that they are diagnosed earlier and patients are put on treatment. It's worthy to know that treatment for lung cancer is complex. Complex because lung cancer is not just lung cancer. There are different molecular subtypes, way and above the different subtypes of lung cancer. There are different subtypes of it. So treatment tends to be more complex, and it can be subdivided into different modalities. We can use therapy, we can use targeted therapies. Those are the immunotherapies. They are currently coming, most of them are coming to the market, and I'm sure there are clinical trials trying to investigate different targeted therapies for lung cancer, not only lung cancer, but other lung cancers. But way and above that, treatment for lung cancer should be decided by the MDT. I'm happy that currently MDTs can be done online, where you have different specialists from different facilities. They discuss a case and try to come up with a treatment option. So the best treatment or the best treatment approach for lung cancer is the one that is based on the MDT approach. And the composition of the MDT can include the radiologists, the medical oncologists, the surgeons. It's a wide team. Next, please. So, like I said, again, lung cancer, the treatment will depend on different factors. Number one factor that sorry for that. Sorry, I know my network was buffering a little bit. So the major determinant is the type of lung cancer we have. We talk about two major. that is the small cell and the non-small cell, and the treatment approaches are quite different. Way and above that, we also look at how advanced is the disease is. That is the staging. And our clinicians will use the TNM, clinical staging for lung cancer. So there is instances where you will go for palliative care or palliative approach, and there are stages like stage 1, stage 2, or where there are cases of local metastasis where the aim of treatment will be curative. And then also we look at the general health of the patient. So we want to use the different functional, the ECOG scores, the general health of the patient. So if we have elicited, if it's a case of the small cell lung cancer, again, there are different subtypes. We talked about the adenocarcinoma, we talked about the squamous, we talked about large cell. So the treatment can include chemotherapy and chemotherapy combined with radiotherapy. The major chemotherapy, the major combinations, basically you will find patients on taxane and a platinum containing compound that is on the early stages, but this one is dependent on the outcome from the MDT. But when we talk about cases of non-small cell lung cancer, it's in small cell lung cancer, it's chemotherapy combined with radiotherapy. It's good that we know that. But under the non-small cell lung cancer, it's radiotherapy plus chemotherapy. So the approach again here might differ in that the patient might start with, depending on the outcome from the MDT, the patient might start with radio and then chemotherapy. So it's kind of sequential rather than about the non-Hodgkin's lymphoma of the lungs. So the treatment approach basically is chemotherapy combined again with radiotherapy. So it can be done concurrently with chemotherapy. So it's worthy to note that for all types of cancer, chemotherapy or radiotherapy, that is either adjuvant or can be given as an adjuvant or neoadjuvant, that is before surgery or after surgery. So besides that, we also talked about the superior vena cava syndrome. In superior vena cava syndrome, there are many things that tend to cause it. An example is when we have a thrombosis. So in case there is an indication of that, we can go for thrombolysis. We can go for catheter-induced thrombosis. That is now, before a patient starts radiotherapy, especially for the head and neck, as a supportive therapy, it's always good that they're subjected to a stent, or basically a stent. So there are different approaches for surgery, and I know surgeons in the room can talk more about this. But as an overview, surgery, depending on the size of the tumor, can take 3 approaches. It can be a lobectomy. So under lobectomy, that is probably the disease has involved like a whole lobe of a lung. And from our anatomy, we know that the right side has 2 lobes and the left side has 2 lobes and the right. So depending on the one which is affected, surgeons can go for a lobectomy. But if it is the entire lung that is affected, again, surgeons will consider doing a pneumonectomy, that is removal of the entire lung. But way above that is a smaller version of, there is a small, I call it a part of it where a wedge or a segmenectomy, where a wedge, a small part of the area that is affected, like it can take a wedge shape, is removed. So it depends on the size of the tumor and the location of the tumor. Next. Like I talked earlier, besides the conventional chemotherapy that we have, lung cancer has been associated with the gene, let me call it like the molecular aspect of it that are involved. And in cases where we have the subtypes, where we have, like, for example, we can talk about the BBL, the genes that are affected. So probably we can go for the immunotherapy, the targeted therapies. There are some that are on the market, and I know doctors currently are prescribing the pembrolizumab. There's atezolizumab. There are new that are coming on the market, and our patients are being exposed to clinical trials, trying to find which is the best targeted therapy to use for a specific lung cancer. Besides treatment approaches, we also have palliative and supportive care. The challenge we have is that most of our patients do come when the disease is a little bit advanced. You look at the statistics for especially the non-small cell lung cancer, like we find that like 55% of the patients will come when the disease has gone, has had distant metastasis, that is to the lungs, to the brain. The key supporting pillar for lung cancer treatment. Way and above, doing palliative care for metastasis, we also look at the symptoms. Patients are presenting with shortness of breath. Patients are presenting with the key respiratory symptoms, and sometimes anxiety takes key. So the psychosocial care and palliative care, generally, they play a big role. So we talk about palliative care, that is palliative radiotherapy and palliative chemotherapy, if the disease is a little bit advanced. We can also manage symptoms, not necessarily using the treatment approaches of chemo and radio. So the palliative care team becomes of help, especially when the patient is having the key symptoms. So among the basics that we do in palliative care, we can have the spiritual support or the psychosocial support. And way and above that, we encourage patients to join support groups. Kenyatta National Hospital runs a very good support care program for our patients on follow-up. So in the support group, we talk about joining the smoking cessation groups, where you try to help our patients in one way or the other on how to stop smoking. Under palliative care, we also talk about counseling and patient health education programs that are run. So under the education empowerment programs, we can talk about healthful living. Sometimes symptoms can be debilitating. So debilitating symptoms will tend to make our patients give up in treatments. So we talk about healthful living. Healthful living will incorporate about healthful eating. Will incorporate avoidance of the sedentary lifestyle, smoking cessation. We look at diet. There's a very large supportive care that is involved in healthful living. Way and above that, we also talk about preventing other diseases. Chemotherapy and radiotherapy, they tend to impact on the immune system of the patient. So we talk about infection prevention as key. Besides that, we also talk about alcohol and smoking cessation as part of healthful living. I think that one cannot be emphasized. Also, exercise is key. We try to encourage our patients. We try to encourage, generally everyone, we should have at least 30 minutes of physical activity. Looking at it cumulatively at around 150 minutes per week of physical activity as part of the preventive mechanism for not only lung cancer, but for other cancers. So there are referral systems that have been established. To help us depending on the locality where you are practicing. So the referral systems, if you tend to have a patient presenting with the symptoms that we talked about, it's normally advised that if you're in a primary health setting, that is on the lower tiers of the healthcare system, that these patients need to be referred to the next level within 2 weeks. So if we can do this, we try. It's in a way helps us to have early identification of cases, and patients are subjected to early treatment, and the outcomes are better when we have early initiation of treatment. So Sorry, you moved a little bit faster. The previous slide, thank you. So in a suspicion index, again, if the patient is presenting with the symptoms that we talked about, we need to subject our patients to an urgent X-ray that is within 2 weeks. For example, if the patient has had a chronic, they're having chronic respiratory disease, or rather they are in a TB treatment and TB is not showing signs of improvement, it's always good that the patients are subjected to an urgent X-ray, and then we refer any suspected case to a higher level. Now, the next slide gives us the referral systems that we have. Next. It gives us the referral systems that we have. So we have the community level and some of the services that are given in different tiers of the health systems. For example, the healthcare providers working at the community level, we can do assessment for TB, assessment for lung cancer. And what exactly do we look for? For example, if most of the patients on TB treatment are in the community. So if we have patients who are subjected, who are on TB treatment, but it's not improving, we can do a cough assessment, we can screen for TB, and if we have a high suspicion index, depending on the NCCN guideline, we are allowed to refer this patient to higher levels. And then we have the primary healthcare facilities, those are the level 3s and level 4s, the dispensaries and the health centers. So they will offer services to include screening, that is assessment of TB and other respiratory symptoms that can increase our suspicion index. But way and above that, they also run the TB clinics now, where patients can access treatment. Besides the TB clinics, there is also, I'm sure, you can also find the clinics for other respiratory diseases. That is on the level 2s and level 3s. Now there are level 4s and level 5, that is the county referral hospitals. They will offer the services that we talked about, that is screening, treatment and TB clinics. But way and above that, they also have services that will tend to include diagnostic criteria now, like the bronchoscopy, the CT guided biopsy, the CT scan. They can do the metastatic workup, and then even the treatment options, the chemotherapy and surgery. They also run the palliative and supportive services. But above that, we have the tertiary hospitals, and currently, we have many. There's Kenyatta National Hospital, there's KU, there's MTRH. But currently, we have the PET scan, radiotherapy, PET scan at KU, and other major treatment sites, that is the tertiary, that's MTRH and KNH, you have radiotherapy services. So depending on the setting where you are and the type of services that are required, we can use these levels to refer our patients. On the lung cancer prognosis, I'm sure several studies have been done, and we are able to give a prognosis. The 5-year survival period, I'm sure, for lung cancer is quite poor, but the treatment outcome and prognosis will tend to vary widely. So the aim for this awareness creation course is to try to increase our suspicion index, and not only that, to try to see if we can have patients diagnosed, susceptible patients being diagnosed at early stages. Lung cancer, when its diagnosis made at an early stage, the prognosis will tend, the prognosis is way better rather than when patients are coming at late stages. We also tend to evaluate the comorbid, the underlying infections or underlying illnesses. So the prognosis will depend if the patients will have other underlying illnesses. Depending again on the setting where you are practicing, we have the follow-up of lung cancer patients. The major ones, after treatment, patients will be followed up after 3 to 6 months, that is after the initial treatment. And then after every 6 months for a period of 5 years. This is not cast on stone. It depends again on where you practice. Some patients will be put on follow-up care like 6 weeks, that's a month to 6 weeks after treatment. So basically, the aim for follow-up care is to try to see whether there is a recurrence, or way above the recurrence, we also tend to assess the quality of life of a patient post-treatment, and then whether the patient will need the palliative or the supportive care. So among the follow-up visits, some of the things that we do is we want to find the history of the chest symptoms, history of smoking cessations, and such like. During the follow-up, patients can also, patients on treatment for lung cancer, we look for other emergencies. We talk about the superior vena cava syndrome, the Horner syndrome. There's also a chance of developing the spinal cord compression as major oncologic emergencies that can develop. So the above is the summary for the 3 sessions that we've gone through in a nutshell. Under the summary, we've said that lung cancer treatment basically is based on the multidisciplinary approach, and the major treatment is offered in a tertiary center. So it's always good, depending on where we are, to refer our patients to an area where they can get the required assistance. Primary healthcare workers can support the MDT, or can support the lung cancer care team in a number of ways, not limited to this, but basically managing symptoms such as dyspnea, cough, pleural effusion. Under the primary healthcare providers, they can also work on smoking cessation programs and offer psychosocial. Way and above that, they can also run the healthful living programs for lung cancer survivors and back to you, the moderator.
Thank you, Solomon, for taking us through that whole class. So that was 3 sessions on lung cancer. We've gone through the signs and symptoms, the epidemiology, the diagnosis, and even the treatment. So you can definitely see the content that we have is very useful. It's comprehensive. And as a healthcare worker, you can really benefit from accessing this content. It's free of charge. You're able to get CPD points on the platforms, the MoH Virtual Academy and the M-Saratani on Google Play Store and Apple Store. So moving on, we have Dr. Valerian Mwenda, who's also going to take us on some aspects of prevention and early detection of lung cancer. Dr. Mwenda.
So thank you, and good afternoon, everybody. It is a pleasure to be back on this platform to discuss this other very important topic. I hope you can hear me very well. So I'll be taking you through overview of the lung cancer prevention and control in Kenya. Solomon has done a very good job in taking us through the clinical aspects of lung cancer, and I think my short talk will focus more on the public health side of things on this very important disease. So I have no conflicts of interest to declare. So that's the outline of my talk. I'll focus on lung cancer epidemiology in Kenya, which the previous talk has already touched on. I'll also look at the lung cancer screening in context, look at the early diagnosis intervention that we've been implementing in the country, and then conclude by looking at the future of lung cancer control in Kenya, especially the policy options that we do have. So and I think the previous speaker has mentioned this. Lung cancer epidemiology is quite interesting. So we do know that there's a major difference between epidemiology of lung cancer in high-income countries or high-income regions and Kenya and other low and middle-income countries. Quite a number of reasons advanced to explain that. And as you can see on the screen there, as an example from the Global Cancer Observatory, the disease burden there, around 3.2 per 100,000 for Kenya. And this compares very well with our local registries. So in this country, we have 2 high quality population-based cancer registries. We have the Nairobi Cancer Registry, a rate of 5.4 per 100,000, and the adult cancer registry, a similar level of 4 per 100,000. So quite a low disease burden in the country across all the sources of information, all the registries. So then the question is this the true burden of lung cancer in the country? And to just try to put this in context, this slide is trying to compare, as mentioned by the previous speaker, smoking is a major driver of disease burden for lung cancer. I think it's one of the risk factors with the highest population attributable fractions, I think, across all cancers and across many non-communicable diseases. So this slide compares the smoking or tobacco smoking prevalence in these selected countries and comparing that with their lung cancer incidence. And as you can see, there are no major difference between the tobacco smoking prevalence between Kenya, Australia especially, and even the United Kingdom and Canada. The figures are slightly high. But if you look at the lung cancer incidence, the difference is not the same. I mean, it's more than I think times 6 or times 7 or even times 8 in some instances, the burden. So there is some additional aspects of the disease burden that maybe we need to look at in our context. And one thing that we suspect could be the reason is similarity between lung cancer and TB. And we do know that Kenya is a high TB burden country. And the fact that these two diseases actually present exactly the same way, they are basically clinically indistinguishable. If you look at those two charts that are displayed there, I don't know if one of you can be able to tell which one belongs to TB, which one belongs to lung cancer, because these two conditions, again, as shown in the previous talk, they tend to share their clinical presentations. So if that's the case, then is there a possibility that we are losing some cases due to being misdiagnosed as TB? And the answer is that is very highly likely, because some information, especially coming from the western part of the country, some evidence showing that a number of people with lung cancer are initially diagnosed as TB, and they're followed up, they're treated maybe as clinical, what you call clinical forms of TB or sputum negative TB. They are retreated even once or twice, and then by the time if they ever get referred for evaluation for possible lung cancer, the disease is already at advanced stages. So this is one of the reasons, but of course there may be other factors within that context that may be driving a different epidemiology that we see. Something else that is very different, I think, with that understanding is we also see different disease dynamics. For instance, this recent study actually done at KNH showed that of all the patients who underwent bronchoscopy and had a lung cancer diagnosis, only a third had history of either current or past smoking. So we do know that in other jurisdictions worldwide, smoking again it's a major risk factor. It's usually quite prevalent among lung cancer cases. But here we see a different picture whereby actually the history of smoking is of the minority, and also our male to female ratio is near to 1 to 1. Usually in most of the other regions in the world, you see the burden of lung cancer following the burden of smoking, and so usually a preponderance among the males. So again, this may point to a number of things. One, maybe a different genetic kind of drivers to our disease burden, and two, possibility of other risk factors, especially things like the use of biomass or indoor house pollution. And maybe this could explain the reason why we find more and more older women, especially from the rural areas, being diagnosed with lung cancer without history of smoking. So then what has been our public health response to lung cancer? So this is, to just maybe, give us a broader context. At the public health level, we respond to cancer in 4 major levels. One is what we call primordial. And here we, design and implement interventions that targets an entire population, like reducing smoking or increasing physical activity. Then we do have the primary level, that's involves preventing, the disease or cancer from occurring in a susceptible individual. An example here is vaccination, like we do for HPV against cervical cancer, but also things like, HPV against liver cancer. Then we have secondary, and here we focus on early disease detection, and this is very relevant for our discussion today. And then tertiary, where we basically are aiming to reduce the effects of cancer once diagnosed. So aiming to, to manage it and support the patients to reduce adverse events, to reduce costs and financial distress. So again, to situate what we're doing for lung cancer in this country, we need to remind ourselves the cancer early detection continuum. That cancer early detection is a principle of two interventions. One of them is screening, and in screening, basically we apply a simple test among a population that is not sick, so a population that has no symptoms. And then we have what we call early diagnosis, whereby we are aiming to, to diagnose or make the diagnosis or to detect the disease in its early stages among people who already have symptoms. So the early diagnosis parts or the concept of early diagnosis involves 3 steps. First is awareness creation and ensuring that people have access. The second step is setting up structures for clinical evaluation, diagnosis, and staging. And then the third step is ensuring that those who are diagnosed have access to treatments within the reasonable periods of time. So usually for cancer screening at the population level, usually consider 3 things. One of them is burden, the second is cost effectiveness, and then whether the available screening tests performs well in the target population. And globally, only 3 cancers are usually screened at the population level. Cervix, breast, and colorectal, and this mirrors our national context as per our national screening guidelines, where at the population level, we screen for the cancer of the cervix, breast, and soon we'll be launching a colorectal cancer screening program. And then for the prostate, we recommend individualized kind of approach to screening, and then we have targeted screening programs for oral cancers and retinoblastoma. So in summary, Kenya has no lung cancer screening program at the population level. And by screening, again, I go back, it's application of a simple tests among the population that is not sick, has no symptoms, to try to detect the disease in its early stages or in its precancer stages. However, the ministry has embarked on 2 interventions for lung cancer. So one of them is an early diagnosis program for lung cancer that we've been planning. It's in the plan, the final planning stages. This is this started in 2022, and we are working on this jointly together with the National TB, Leprosy, and Lung Health Program and the National Cancer Control Program. There's steering committee team that has county members, representatives, pulmonologists, physicians, basically all the the relevant experts around lung health and lung cancer specifically. So the features of this program will be targeting 10 high burden TB counties. It's supported by GF. So far, we've finalized on the concept and the proposal. We have a draft clinical guideline. We've also developed healthcare worker training materials. So basically, as soon as the final assenting is done by the ministry leadership, we should be able to start this project. And so we are situating lung cancer early diagnosis within the existing TB response or control structures. This is the summary of the structure of this program. So starting again with people who have symptoms, these symptoms are indistinguishable, so that's why we're using the TB program as an entry point. And then, so we start with the diagnostic evaluation for TB. Of course, we do classify TB cases in those 3, whether bacteriological, clinical, or people having other chronic lung conditions. And then for those who have bacteriological TB, if there's no improvement at the 2nd month, and for those with clinical, no improvement by month 1, and all of the people who have other lung conditions, then all these are referred to get a chest X-ray that is read and reported to by a radiologist. And those found to have suggestive features on chest X-ray, so features as suggestive of lung mass or possible lung cancer, they are referred for chest CT scan, also supported by GF. And then again, those with features on CT scan suggestive of lung cancer, they are referred for biopsy and histology. And if lung cancer is diagnosed, those patients are referred to our cancer centers, both the national and the regional ones. So the second intervention, you've already been taken through. So you have content that Solomon has taken us through. That content is available again on the Virtual Academy, and you can see the link there. It's also available on the M-Saratani mobile application that is available on Google Play. Anytime you onboard those materials, you're able to learn, and you also get CPDs as well as certificates. So I made this same presentation a week ago during the RESOC symposium in Nairobi. I don't know if some of people in this call were able to attend, even virtually. So I posted this question to the experts who had gathered during the symposium. So I asked them, on the policy side, would they advise Kenya to plan and implement a lung cancer screening program at the population level? And by screening, I mean targeting people who are not sick and applying a simple test. And I hope the participants here know that the screening modality for lung cancer is actually what we call low-dose CT scan. So it's a CT scan, but with a low dosage as compared to the diagnostic CT scans. And so I asked them, if yes, what structure will such a program take? And will it be population-based or would it be targeted? And I think there was a resounding answer from the experts gathered during the symposium that they wouldn't advise that Kenya implements a lung cancer screening program. However, a early diagnosis program that is integrated into the existing lung health control structures like the TB program would be feasible, and it will make a lot of sense. And also we can think of maybe doing a targeted early diagnostic interventions among especially people at high risks, people like smokers, and also people with the history of exposure to indoor air pollution and other risk factors that I read on. So that's the end of my talk. Thank you very much, and back to the moderator.
Thank you, Dr. Valerian. I think that was a very informative presentation. Let's see the Q&A. So there's a question: a person treated for pulmonary TB like 20 years ago, does he still stand a high risk of CA lung? I don't know, Dr. Valerian, could you have the answer to that?
Thank you. So the question again is: a person treated for PTB like 20 years ago, does he still stand a higher risk of cancer of the lungs? So yes and no. It depends with what form of TB was treated. So we do know that TB itself may not be a risk factor for lung cancer, but post-TB fibrosis is a risk factor for lung cancer. So depending on the stage and the kind of destruction that had happened in the lungs, the inflammatory response, if there was a lot of lung cancer, post-TB fibrosis, yes, that is recognized as a risk factor for lung cancer. It's not one of the major risk factors, it's not on top there, but yes, it's a recognized risk factor.
Okay. Then someone who was a heavy smoker, quit some years ago, do they still stand a high risk of lung cancer? I would say yes. What do you think?
Sorry. Yes, they do. So the risk reduces, but even after stopping smoking, your risk does not equate that of a never smoker. So we need to encourage them to stop because that reduces the risk, but the risk does not reduce to zero, definitely, of course, and does not even reduce to become equal to a never smoker.
But I think from your study or from the study you presented, there is also data showing that almost 50% of people diagnosed with lung cancer are actually not smokers even.
Actually, it's more. It's 68%. So
60.
that's, yes, that tells you that in our setting, many other factors may be part of the mix, whether genetics,
Mm.
whether environmental pollutants, whether, you know, other risk factors, are recognized risk factors. Maybe the infections, maybe they play a major role as compared with other regions. Yeah, so there may be other factors in the mix.
Okay. There's a question on recurrent gastric ulcers, if they can lead to cancer, and the scope of lung cancer in Kenya, and especially in Kiambu County and Meru County. The first part of the question on gastric ulcers, I think that will be covered when we do the GIT sessions. But either way, I would refer you, Tony, to the virtual academy. You'll find some content there on the GIT cancers, and I believe that question will be answered. In terms of the scope of lung cancer in Kenya, and especially in Kiambu County and Meru County, is there anything unique about these two counties and lung cancer? Dr. Valerian, do you know of anything special about these two counties?
Top of my head, I know they are part of the 10 counties you're targeting because they're also high TB burden counties. So other than that, still lung cancer is not at the moment, does not feature within their top top five cancer types. I remember one of those counties we were with them last week during the National Cancer Strategy dissemination, and you know, each one of them was sharing with us their top 5 cancers they are seeing in their counties. So majority of the counties in Kenya, lung cancer does not even feature in top 10, which is a picture in the country. I think it's in the countries around number 13 or 14 there. So, but of course, again, is within the context that we just discussed. So those two counties, they'll be the focus of they'll be part of the 10 that you're focusing on in the first phase of the early diagnosis program.
Okay, thank you. Someone is asking, is genetics a predisposing factor to lung cancer? I believe we've answered that. There could be some genetic predisposition. Someone is asking, can pneumonia lead to cancer? Dr. Mwenda, do you want to answer that?
That's clinical. Maybe it would have gone to Solomon, but so pneumonia can't cause. I don't. Is it asking about whether it can cause? Let me see. No, it can't.
Pneumonia
So
can lead to cancer.
no, yes, but now the symptoms that some, especially the chronic types of pneumonia, present with can mimic or can mask lung cancer. So if somebody's been treated for pneumonia, they're not getting well, those are some of the people you're seeing you. That's the kind of people Solomon mentioned that you need to investigate further and find out why, if they could be having a chronic lung condition, one of which is lung cancer.
Okay. There's a question on the use of herbal remedies and nutritional supplements in the treatment of cancer, and as well as the importance of diet during treatment. Solomon, I think that would be best answered by you as an oncology nurse. What are your thoughts around herbal remedies and nutritional supplements?
Thank you. I know there is a talk of that, but you know, most of the treatment approaches we use in Kenya are regulated. We can talk of use of nutritional support as a supportive therapy to cancer care, not only limited to lung cancer, but use of herbal remedies. I don't think whether in Kenya we've gotten to that point. And you know, most of the treatment approaches we use, they are taken through very rigorous approval processes. So currently, I'm not aware of any herbal remedies that have been taken for any investigation and approved. But they can, nutritionally, supportive care can be used, and we have nutritionists and dietitians who can help in that. But as a use for cancer treatment, I wouldn't encourage for that.
Okay, thank you. And I think that is one big bone of contention, especially for cancer patients. We've been seeing a lot of mixing up of the conventional medicine with the herbal medicine. And I think that's actually a very dangerous step to take. We know, the anti-cancers themselves are very heavy on the body. They're a bit toxic. And most of these herbal products, actually, they're not quantified. If they tell you they've crushed two leaves of this plant, you don't know the content of that, the actual content of that product. So you could actually be adding on more toxicity on top of the other drugs that you're taking. So this is an area that we need to actually tell our patients to keep off completely. And I think also for the nutritional supplements, we've had the same issue. People are buying these very expensive nutritional supplements being advertised by certain companies. They're saying this one will cure, I don't know, diabetes and what, and cancer. And that's a very dangerous path to take. We've seen sometimes a patient is not responding to treatment. And when you dig deeper, you actually find out that they've been taking these supplements on the side, which are interfering with the treatment. So it's important we warn our patients on that. There's a question on if someone has post-TB lung fibrosis, how soon would you recommend getting the CT scan screening? Dr. Valerian, was this covered in the algorithm?
So there's some details that are not there because we had summarized it. I'll say this: if the patient is symptomatic, as soon as possible. If they are not, first of all, there's no screening. It's actually an early diagnostic procedure. So if really they are not symptomatic, I mean, they are okay. They were treated, because majority of people are treated with not majority, but a substantial proportion of people are treated for TB, depending on the stage the TB was. They will get cured, but the lung will be scarred a bit. So if the person is not symptomatic, then there's no need for routine, CT scans for everybody who has some fibrosis on radiographs. But if they have symptoms, yes, they do qualify too. So you realize that the proposed program is more of a early diagnostic program for people who are suspected to have, who are either diagnosed to have TB, but they're not improving after treatment, after a certain period of treatment, or they are suspected to have other lung conditions. So if the person is not symptomatic, then there's no reason for them to be to undergo the CT scanning.
Okay. There's an interesting question here on the risk factor of CA lung in cannabis smokers and tobacco smokers. Is it the same?
That's a very interesting question. So it doesn't seem to be the same. It seems that tobacco has actually a number of carcinogens that some other smoked things may not have. So we do know that the what you call the population attribution fraction, which is a measure of the linkage between a certain risk factor, is a quantitative measure of the link between a risk factor and the disease it causes. So you do know that smoking has the highest for lung cancer. So we have all these other products that have come now in the market. Some are more recent, but digital economics have been there for years. But the straight answer is that it's other pollutants that go to the lungs that are also dangerous, but smoking tobacco has the highest link with lung cancer.
Okay. Solomon, there's a question. If surgery is done, like pneumonectomy, what's the surety of life? Because lung is a breathing system. I think this is more of like what is the outcome of the pneumonectomy?
Thank you for that question. I need to get the question clear. They are asking about the surety, or exactly what is the question asking about?
Yeah, the surety of life.
Well, it has been proven, surgery, it's a curative form of treatment for major cancers. And like I said, depending on the size of the tumor, the surgeons will determine on which type of surgery to do. So a pneumonectomy can be preferred. Such has shown that yes, the quality of life might not be that good, but chances of survival are there.
Okay, okay. So you're saying there could be some relief of symptoms, but perhaps they'll still not go back to the previous status of life, quality of life.
Sure, yes. It will take a while.
Okay. So I'll combine these two questions, Dr. Mwenda, on the issue of cooking with firewood as a risk factor for lung cancer, and also for the non-smokers who had cancer, were they staying with smokers? Hence, they were indirect. Okay. This is also called secondary smokers. Yes. So what can you say about the two, the use of firewood as a risk factor, as well as the secondary smoking?
So for the first question, yes, cooking firewood is a risk factor, especially in poorly ventilated kitchens. So that's actually one of the reasons. And again, this was discussed actually in detail during that symposium, the RESOC symposium a week ago. The fact that, in the rural areas, especially women, some have been cooking in that kind of situation since they were young. And so a number of them have been seen with lung cancer. Actually, it was very interesting that a number of clinicians there, senior clinicians who are there, they were mentioning that actually they are seeing more of women with lung cancer than men. So on the second question, that's an important consideration, maybe as you interpret the results of this MoH study at KNH. It's very clear because I think they administered questionnaires on these patients. So those variables are usually clearly asked for, but there's also the issue of dose dependency, because you do know there's a dose response relationship between smoking and lung cancer. So either way, you would expect that the dynamics of disease will be much higher among those people who are smoking as opposed to the ones who have secondary smoking. But again, that's an important aspect to maybe look at in future studies.
Okay. There's a question on clarify on the risk of drugs that can cause lung cancer based on people with chronic ailments such as asthma, etc., who are on drugs frequently. Solomon, do you have any thoughts on this?
I don't think whether drugs used for asthma or rather chronic pulmonary obstructive diseases will predispose one to lung cancer, but the disease in itself is a risk factor. We talk about chronic respiratory diseases. The disease in itself, it can either be asthma, it can either be COPD. It's a risk factor for lung cancer. For the reasons Dr. Valerie has explained, it causes the cavitations and the vibrations. Probably that can be related to the lungs. So I look at the diseases as a risk factor as opposed to the drugs.
Okay, thank you for that. Can someone having leukemia be diagnosed with lung cancer? Is there any relation, Solomon?
Yes, the use of chemotherapeutics is a risk factor. And the first line treatment for leukemia basically is chemotherapy. So radiotherapy or chemotherapy predisposes individuals to cancer, and lung cancer is one of them. So it's a high suspicion index. There's a high risk for developing a secondary cancer that can either be lung cancer. Yes, there is a risk.
Okay. There's a question, I think this was on the diagnosis part. The question is, do we do a plain CT scan of the chest or HRCT?
I think Dr. Valerie can help with that.
So thank you. A plain CT will do. Yes, there are some characterization of some lesions, especially the smaller ones that may require high resolution CT. But a plain CT as for the the early evaluation aspect should be enough.
Okay. All right. So this is another tricky question. How can we differentiate early lung cancer and clinical TB? Is there any data on clinical TB and lung cancer? I think Dr. Valerian, that's where you are saying
Yeah. So
there's an algorithm.
yeah. So clinically, these diseases are indistinguishable. It's only high index of suspicion. So, and that's the reason why in this proposed program, that's it's more of a phased public health program. So we start with these 10 counties, but hopefully we'll be able to extend it to the other, to all the 47 counties. So the thinking is, since because of the robustness of our TB control program, anybody who has chronic cough and all these symptoms most likely will be started off in a TB diagnostic pathway. That one we know. We know our TB infrastructure is quite robust all the way to level 3, even level 2. So this program is premised on that strength, that these people are not improving, because if you have an alternative diagnosis, you won't improve on TB treatment. We expect that within 2 weeks, if somebody has TB and they started on treatment, there's very marked improvement. When that is not there, then these are the people we channel into the, and there are those features that are listed, things like pleurofusions and indefinite masses, all those things on even chest X-rays. Those are the ones that now will be able to inform the clinicians, the primary healthcare workers to advise these patients to go into the further evaluation pathway.
And maybe if I can also come in at that level, I know Dr. Valerie talked that said that we do not have a very robust training program. But for a patient presenting with TB, I think one of the diagnostic criteria we do is sputum cytology. And it can be of help, especially to increase the suspicion index for cancer, but the clinical presentation will more or less then be the same. But this way and beyond the radiological studies, we can consider sputum cytology right to lead us to the other.
Okay. I'm seeing someone else is saying TB and lung cancer can actually coexist. They once had a patient who turned smear negative after 1 month, but was still coughing. So CT scan nailed the lung cancer diagnosis. A high index of suspicion is needed. I think that is one thing we're really trying to pass across, that as clinicians, we need to think of other differential diagnoses so that we can get these cases in good time. I'm seeing a question back on the cases in Kiambu and Meru, and they're asking about the use of pesticides and herbicides, and if there could be a relationship to the lung cancer cases. Dr. Valerian, you mentioned in those counties, they didn't even report lung cancer as among the top 10 conditions. Although we've also discussed that there's a lot of misdiagnoses and underdiagnoses. So perhaps people are being managed for other things, maybe COPD, maybe asthma. So maybe that's why we are not seeing it. But is there a relationship of the herbicides and the agricultural pesticides and lung cancer? Is there anything there?
So on the environmental side of things, the only ones that have a strong association with lung cancer is asbestos, radon, and dust. These, the kind of dust that comes from the industrial processes. So for the chemicals themselves, globally, not so much strong evidence. But I think I need to state here that there's a lot of worry and concern in the public that, you know, our agricultural practices are so bad, they may be contributing to not just lung cancer, maybe other cancers. And maybe to just inform the person who asked the question and also the other attendees here, that's the reason why actually this issue found its way into the National Cancer Strategic Plan. So the next strategy that is covering the next 5-year period. If you look at that strategy, you find that there's actually an intervention that is targeting, or interventions actually, maybe not one, that are targeting this issue. So improving our surveillance and ensuring that we can be able to reassure the public. If we identify some are maybe the ones that are already known to be risk factors for cancers and they are being used because of lack of surveillance, then we ensure that we remove them. And if we find that the ones that people are fearing they may be, but they're not associated, then we can reassure the public. So it's a very, very critical topic in our country today.
Okay. There's a question on whether HBV can cause lung cancer. Solomon, do you want to answer that? Hepatitis B and lung cancer.
Hepatitis B, basically, it's a high risk for hepatocellular carcinoma, and then probably we can relate it that lung cancer can come in as a secondary malignancy. So based on that, we can say that it's a risk factor because Dr. Valerie will tell you that epidemiologically the hepatitis B virus is the major cause for that. So I'm looking at it from a secondary malignancy as a metastatic disease.
Okay. The question on some clinicians asking for PET scan before starting treatment. What's your opinion on this in respect to treatment initiation? I don't know which of you can take that or if we can shelf it for next time. Solomon, is there any correlation between PET scan and treatment initiation?
Sorry, I was muted. Not really, but PET scan is required, especially it's required for, let me say, for metastatic workup and such. But for treatment initiation, it's not a must. I don't think whether it's a must. Maybe Dr. Varali can respond on the same.
Yeah, same thing. I don't think it's a diagnostic, procedure. So for follow-up maybe and some other specific indications, but for pre-treatment initiation, not necessarily.
Okay, so this is the last question, and it's been asked twice in a different way. Can lung cancer be cured? Someone asked that, and someone else also asked about the prognosis. So our speakers, what is your say on that? Can it be cured?
Maybe Solomon can mention yes in the clinical areas. I would say yes and no. So early stages of lung cancer, and I think that's why surgery has a role. It can be cured. More advanced cases of the disease, of course, cure may be difficult.
Solomon?
I echo that, but the challenge we experience in most of these developing countries is that we are getting cases when it's an advanced stage. So at early stages, most cancers can recede. It's curable. Let me use the term, it can go under recession. But basically, most disturbing thing is that we receive most of the cancers at advanced stages when the primary aim of treatment is basically palliative. So when surgery is indicated, I think there are chances of cure.
Maybe Solomon, in your clinical experience, have you seen maybe a number of patients with good outcomes with lung cancer?
The numbers are so few for lung cancers. We see a very few of them who come, but the challenge is that they come at very advanced stage. So I cannot really record of any success story, but palliatively, we are doing well. I will love to find a case where we have early diagnosis, maybe a stage 1 also, but for the prognosis is not usually so good. And also you look at especially the non-small cell lung cancers, patients are coming way, it can mask, it can mask the symptoms, and most patients don't know that they have the disease. And most of the patients who come, they come at an advanced stage when the primary aim is purely palliative. I'll be glad to find an early stage and probably report it sometimes later.
Okay. All right. So as we wrap up, Dr. Valerian, I'm seeing there's a question that now, after all the statistics about how our smoking, our rate of smoking is high, yet our lung cancer incidence is low. What would be your parting thoughts, or maybe, yeah, what would you like to leave us with?
So thank you, Jeffrida. So I think my parting shot is we have reasons to believe that we have a higher lung cancer burden than we see from the epidemiological data that we have. I think focusing on early diagnosis as a country and investing our resources there, and all those components, so creating awareness in the population, then supporting our healthcare workers to be able to suspect lung cancer and do early referrals, and of course strengthening our diagnostics, referral and treatment services. I think all of that working together can assist to improve the outcomes of lung cancer, and maybe give Solomon reason to smile. Thank you.
Okay, Solomon, your final thoughts as we close?
Thank you, Dr. Jeffrida. My final thoughts still revolve around early detection and early diagnosis. So basically, for us to achieve this is for the healthcare providers and any other members on the call, let us increase our suspicion index. And perhaps you've said that because lung cancer will tend to mimic the symptoms exhibited by other respiratory symptoms, I think in instances where we treat and there are no signs of improvement, let's always refer, or rather have a second opinion on the same. So early diagnosis is the way. Thank you.
Okay, thank you. So my parting shot is that to equip you with the knowledge you require to have this high index of suspicion, kindly look out at the MoH Virtual Academy. Under non-communicable diseases, you'll find the cancer courses there. It's very helpful for you as a primary health worker, wherever you are. There's something you can do about this. So just go through the content. You'll get a certificate, you'll get CPD points. You can also use the M-Saratani on Google Play Store. You can just read it on your phone as you travel, as you wait for your patients. Knowledge is power. So thank you all for attending this webinar. We still have other webinars coming up. So just look out on the KNH website. Thank you, KNH, for your support as always. We'll end it at that. Have a good evening.